webinar in the series of 3 webinars on the Zika virus epidemic. You all know that our first webinar was an introduction to the virus, its epidemiological and biomedical aspects. And the second webinar we had last week was looking at the virus from the health system's perspective, how the health system can be strengthened to respond to the epidemic. Today we are shifting gears and we'll be looking at the communication and community engagement aspect in the fight against the Zika virus epidemic. Before we start, I would like to thank our guest speakers today, Dr. Gamhir Wajeh, working in the Pandemic and Epidemic Disease Department at WHO HQ, and Mrs. Odugle Kolev, working in the Department of Health Service Delivery and Safety, also at World Health Organization headquarters. So without any further delay, I would let the speaker start the webinar. Thank you.
Okay. Hi, can you hear me? No, it's mute.
Yes, yes, we can.
We can hear you very well.
Hi. Good morning, good afternoon. I'm not quite sure where everybody is. Thank you. This is Gaia Gamhir. I'm really pleased to be here. My colleague Asia is just sitting across the room from me, and I'm sure she'll jump in a little while. Thank you so much for inviting us to share with you some of our experience and thoughts, and hopefully we will also learn something from participating in this today. The plan today is, I understand you can't see me, so I'm very happy because I look very scruffy today. How do I go page down? Okay, so I'm in the next, hopefully I will not speak for 45 minutes, hopefully in the next 20-25 minutes, I want to take you through the journey that we've been on for the last few months. Our colleagues in the Americas started this a year ago. We've been involved since about end of January. So I wanted to recap some of the issues that we are worried about and why risk communication, community engagement is so important in this response. Look at what risks exist, about which people who are at risk need to know. The current approach that we've been using, and maybe we will get some ideas from you to improve that approach. Quickly go over some of the achievements so far and open the floor by sharing with you some of the ideas we have about what the next phase should look like. This problem is not over and we need to shift gears, and different priorities will arise in the next 6 months. If that's okay, you know about the history of Zika. I don't need to tell you about that, but I think it's important to refresh ourselves why we are worried about Zika, because Zika is, in many people, in most people, it is a mild disease. It is definitely milder than chikungunya and dengue and yellow fever, which are also diseases spread by the same Aedes mosquito. The fear, obviously, you know, it is about the neurological complications and some of the congenital complications. And you've probably heard about this the most, that microcephaly in babies of women who've been exposed to Zika and maybe other infections is the concern that we have. And of course, most of the story of this particular outbreak focuses on the Americas, but as you will see in our discussion, it has a bigger influence and impact across the world. You don't need this slide. I have created more slides than you need, so you can use it for reference later. But basically, the important thing here is it's fever, body aches, a rash, muscle pain, last 2 to 7 days, sounds like many illnesses we have. The important thing is that there is currently no specific cure for Zika, and there is no vaccine available. And these two things really impact on how people perceive this risk. At the moment, the best form of prevention is protection against mosquito bites, and we will talk later, maybe protection from pregnancy as well. You know already this virus is circulating in Africa, the Americas, Asia, and the Pacific. So it's pretty widespread. Nearly 60 countries you'll see in this map are reporting cases recently. And sexual transmission. So while the predominant mode of transmission is and we have evidence that sexual transmission is a mode as well as blood, and now people are looking into breastfeeding and other things. So this is all important to know before we go into risk communication. So really the fear and the concern that has been driving this response, particularly by women living in the Americas, is about the congenital malformations such as microcephaly. And less talked about, the autoimmune and the neurological complication like Guillain-Barré. So within a few hours, you could go from being relatively okay, feeling a little sick, to being paralyzed. So this is a really serious thing, but people seem less concerned about this, and I'm not sure why. Apparently there are about 4,000 cases of microcephaly and about 1,000 of Guillain-Barré in Brazil. These are not, please don't quote these figures because the figures keep changing, but just to let you know, it's not a small thing, it's a very big thing. And this, if you like, is the image of this baby with microcephaly. And this is the image that has been haunting people in this area. So looking at this, so what are the 4 risk factors that really inform what we are doing in risk communication and community engagement? The presence of the Aedes vector is a big risk factor. I want to talk to you a little bit about that. Sexual reproductive health status is a big risk factor, and particularly in the Americas, this is a very big risk factor. Social, economic, and cultural factors, and then of course others. There are reports that chikungunya infections could be associated. So there's a whole box of risks that we don't know about. So this famous Aedes vector, I must say, I'm a medical doctor and public health person, but I've learned a lot about mosquitoes in the last few months. So the Aedes vector, you'll hear about the 2 species, the urban one and the forest one, that it bites during the day. But the reality is this vector exists in an area where there are other diseases of mosquitoes who bite during the night. So really protecting from mosquitoes day and night becomes a very important thing. To give you an idea of how clever and strong this vector is, this vector arrived for the first time in the Americas in 2013. Less than 3 years later, 45 countries and territories have chikungunya, which is also spread by this vector. So you see, while there have been very many mosquito and vector control programs in the Americas, it's very difficult to control this vector. So this, again, is a really important factor about this. Here's a little map. Again, don't quote WHO, it's not a WHO map, but I thought this one looked more colorful than the ones we have. Just to show you, look at this belt across the world, this whole belt across the world where this mosquito is. So when we got confirmation earlier this week that this same mosquito and this same Zika virus species is present in Cape Verde in Africa, you see why everybody is so concerned. The second risk factor is about sexual reproductive health. And I really want to highlight this because it's something that has been very difficult to talk about. This girl is 15 years old. She's outside a hospital in Brazil, and she's very lucky because it's not like Africa. People do have access to good hospitals. Most babies are born with trained personnel. It's a very different situation. She's 15 years old. She's not married. She's from a poor family. This is the phase of Zika in the Americas at the moment. And it's very important, I don't know whether all of you are students or practitioners, that we bring many different specialities and expertise to bear on any emergency, whether it's risk communication, community engagement, or anything else. To remember that we're dealing with people who all our specialities converge, and they have to experience and live with this. 23 million women lack access to contraception in the Americas, and this accounts for 75% of unwanted pregnancies. 3/4 of unwanted pregnancies are because there's 23 million women do not have access to contraception. Nearly 1/4 of adolescent girls start having sex before the age of 15. So even when services exist, where education exists, this group and their sexual partners are outside this. This is the highest globally. Very large number of abortions take place, more than 4 million, and 95% of them are said to be in unsafe conditions. This is also because of quite strict cultural but also legal framework in these countries, but it has not stopped women from having abortions. 750,000 women were hospitalized for complications related to this. So this is a really serious issue. 1.68 million women were raped each year in this region. This is very difficult. So when we tell women, delay pregnancy, don't get pregnant, this is a very big ask. There are recent studies, and I've given the references, that young, poor black, brown women are the ones who suffer most from these policies, and they're the most likely to contract Zika. And they're the ones who will face the hardship. We see many cases of young girls supported by their single mothers in their 40s and 50s, 3-4 generations, now with a child with very severe disability and one or no income coming in. So this is a really, really important thing to remember. I'm going through all this just to remind you that risk communication and definitely community engagement don't start with science, or they don't start with messages. They start from understanding the situation of people and the hardships they face. Since 2008, there has been a regional program for sex education. There's been a regional program for sex education, but of course not uniformly implemented, and of course because of cultural and religious demands and perceptions, mainly they focus on abstinence. But it doesn't stop young girls and boys from having sex early. Initiation, as I said, is very young, about 16.5 years for boys and about 15 for girls. This is, I call them men and women, actually they're boys and girls. So the 3 levels of risk: the social and religious context, the early initiation of sex, unmet contraception need, restrictive abortion laws, and penalties. And then low levels and scope of sex education, and of course, attitudes and knowledge of service providers. So if we look at the continuum of support needed for sexual reproductive health, you see that WHO has guidelines on antenatal care, management of newborns with microcephaly, and even support to families. But the prevention and delay of pregnancy in women and girls is a missing link. And to recap for you, since May last year, these are some of the messages that are coming from the region: no mosquito, no Zika. This is a tough one. We know environmentally we can't get rid of this mosquito. No Zika is difficult because it's a viral disease spread by vector, by sex, by blood, by many things. So we think we will all get it to some extent. Delaying pregnancy when there are no services or environment to do that is a very tough one. Protect from mosquitoes, wear long sleeve shirts and trousers. I mean, if you live in the tropics, I'm from the tropics, I'm from Sri Lanka, this is very difficult advice to follow. There was a survey of pregnant women in Puerto Rico because of Zika there, and they just said, no, we can't wear clothes that cover our body. We're hot anyway, we're pregnant, and when you tell us that we should use condoms and have safe sex with our husbands, are you telling us that they're being unfaithful to us? So there's a lot of complicated thinking going on around this. We know that there are 500 million people who live in the Americas. 3/4 of them live in cities. And this is another reason why vector control is so difficult, because this mosquito has adapted so well. They can breed on a drop of water on a leaf in a tree. Right? If you had a teaspoon of water, the mosquito is going to have a big family. It's a relatively prosperous region. Unemployment rate is not so bad. Economic growth is slowing down. Literacy rate is pretty high. And this also helps us design risk communication and target it. Primary education completion is also high. So we know that risk communication is not telling people what to do, but to have interactions with people in a way that they're able to take informed decisions to protect themselves. So we are not for forcing people to do anything, telling people to do anything, but our job is to understand the science, the threat, the risk, as well as the context and the reality and the beliefs people have. And Asia is much better to talk about this than me. But the goal is that they take decisions to protect themselves. They find solutions that are suitable to them. Really we warn against just sending messages, printing leaflets. So really, I hope that this is a thing of the past. I hope Ebola taught us that this doesn't work, and that we can use a special type of science called social science, which includes anthropology. There are many, many subspecialties in order to understand, adjust, support, and create these enabling environments. So that was all the background. So when on February 1st, a public health emergency of international concern was declared by WHO. So just as a tangent, only the World Health Organization can declare a public health emergency of international concern. We do it based on the risk assessment. The Director General of WHO is legally allowed to do this, and when that happens, a set of things happen in the world. Travel restrictions or advice can be given. Response steps up. All governments have a responsibility to do certain things. And when we declared this, of course, we needed a global strategy for Zika response. And you can find all of these on our website. And our strategy was along 3 lines. Surveillance, obviously it was very important to see where this was. Not just surveillance for Zika, but surveillance for the complications. The second is the response pillar, the health operations, and the third is research. As you know, the causal link between microcephaly, Guillain-Barré, and Zika at the beginning was not clear. It's getting stronger, but in WHO, when we say there is a causal link, we have to be very sure. So there's a very strong accelerated program to figure that out, and also research for diagnosing and for a vaccine and other treatments. So these are the first and the last pillars. The middle pillar is the health operations, and in it, for the first time in 68 years of WHO's history, we prioritized in a very big way risk communication and community engagement. Community engagement has always been a mainstay of outbreak response, but this time it became very institutionalized, and in fact, 15 million of the 56 million US dollars required for the whole response was allocated to global partners and countries for community engagement and risk communication. So this is a really big change for us. And then WHO, within a month of that declaration, we developed a guideline on risk communication in the context of Zika virus. WHO can't just write something and call it a guideline. It has, it has certain standard criteria, so that's why it took a month. But this was a very shortened emergency process, and it was to complement existing things. PAHO, our Pan American Health Organization, had already done a step-by-step how to do community engagement. Because in the first few months of Zika in the Americas, they realized that most governments did do some things. They did public communication, they had media spokespeople, they had public service announcements, and they had material. But they were not getting into proper engagement, so we needed to support them. So basically it was developed for any manager working in this area, as well as all of these, you can see policymakers, anybody who was involved in any aspect of it. And then the scope was really target audiences. You can see here pregnant women and girls of reproductive age, community organizations, schools, healthcare workers. So we wanted travelers, policymakers, media. And we outlined 5 strategies. Public communication, which we felt was already happening in the Americas and in local language. What we call translational communication. Translational communication is really taking science and turning it into a format that, say for example, my children or my mother can understand. Digestible. Stakeholder coordination becomes a very big thing. Currently, we have more than 100 agencies and experts coordinating with us on a regular basis. community engagement, and of course, the center of all of this is dynamic listening. So if we're not listening and understanding, we can't do any of this. So this is the way we saw it initially. The challenge for us is, as soon as there is an emergency, there is a pressure on WHO to respond. And the ability to just grab a few things and start to give a framework, I think, becomes more important than going into detail, because the details can be done by the experts in those areas. What my job is at global level is creating the space and the frameworks and to make sure that some of the work is supported. So the main messages have been protect yourself from mosquito bites, and it's a very delicate issue because, as many of you know, His Holiness the Pope also made some statements, but he also made some statements announcing that family planning could be acceptable in this particular situation. So I think everybody at church, everybody is trying to meet the requirements, and there are many faith-based organizations working on the ground, and our networks tell us who interpret the scriptures in a way that protects people as well. So I think but it's still delicate. It's still delicate. And the biggest issue for risk communication is uncertainty. So people would say, does Zika cause microcephaly? And as a science and evidence-based organization, we would say, well, the evidence is getting stronger, but we're not sure yet. And as soon as you say that, it becomes very difficult to communicate. So these are communicating uncertainty is a very big thing in the work we do. So I won't go through all of this. Please look at the guideline, and I put a link to it. It's about dialogue. It's about being the first, being fast, and being frequent. In past emergencies, if I look from humanitarian emergencies to H1N1 pandemic to Ebola and others, if we didn't get up there with something first, it is going to be filled by others and maybe by rumors and so on. So I think this is a big issue to be fast. Creating and maintaining trust is really, really important. And I think Asya might talk about that. And not to be focused on numbers only, because experts tend to talk about cases and deaths and suspects and microcephaly, whereas we should be talking about people who are sick, people who have died, and babies with microcephaly. And the language is very difficult for people working in emergencies because they're using a shorthand, jargon, but when we speak with those affected, if we don't appreciate the humanness of this, it becomes very, very difficult. Recognize barriers, and then we gave some tools to identify them, and actually observing, understanding what's going on. And really, the last line is really not telling people, but engaging and empowering people. Human societies survive with or without experts and with or without WHO. They have their own mechanisms and their structures and their coping and their survival techniques. So it's for us to understand, not for us to tell. But when the dialogue is there, it's for us to give the information they need in a way that they can understand and digest. We also mentioned that the focus should change as the epidemic evolves. And this is very true now. In the beginning, it was mosquitoes, and now the focus is much more sexual reproductive health and health services and all of the things around that. Obviously, doing big vector control programs is good because it will reduce the risk in your environment, and it also makes people believe that their governments are doing something. It also gives them something to do. We have to be careful because it's very limited. The evidence about only using vector control is limited. So I think people who live with these vectors in tough urban situations need other things too. So vector control should continue, but we need to not put all the burden on them. Control the vector, cover yourself, don't have sex. It's very difficult. The messages we're giving, it sounds like we are putting all the burden on them. So I think a combination of them and authorities and us is very important. Obviously, the focus is going much more to pregnancy, prevention, management, monitoring, and so on. And of course, travel. Everybody knows about the Olympics. Everybody's very excited. So for now, 500,000 people live in the Americas, and we're thinking, okay, it's their fate, you know, they live with this. Now everybody else is becoming excited. Should I go to the Olympics? And this is going to be a tough period for communicating risk. We've said some things, but it doesn't mean it's a simple thing. And managing rumors and anticipating what people will think in advance. So I think travel health, travel advice, and the fact that we are in an interconnected world has made this relevant for everybody. Our key issues in this strategy was about working in partnership with governments and agencies, using social science to understand needs and beliefs, building capacity quickly to transform information into communication resources, and educating stakeholders and message multipliers. UNICEF, WHO, PAHO, and Red Cross got together and did a community engagement guide, so that everybody working at country level was using the same thing, and we were not giving contradicting advice. We also, for the first time, did a knowledge, attitudes, and practice survey resource pack. And this was a request by governments in Latin America and Caribbean. They acknowledge they're doing public communication well, but they don't know where to start with this. This is not an extensive resource pack, but it gets them started on some ideas. And then what a really fun thing, and we are trying to use technology, the Zika app. I hope some of you have downloaded it, and if not, you will after this. It's available in iOS and Android versions, English, Spanish, Portuguese, and French. And it really is an easy way to access all the knowledge. And as the response evolves, we will add new things. This is my busiest slide. This is to show all the things that we've done since the beginning. I'm not going to read through all of it, but some points. We started fast. Before the emergency committee was convened, we convened our partners. So before it got big, we were working together. And that is a principle in public health, that no one, no agency, no even a government, nobody can work alone. And that has reaped a lot of success for us. We decided, while our communications colleagues put out press releases and things, we worked on educating journalists. So we accessed the World Federation of Science Journalists, and we sent education packs to them, not news, but education about all of this, so they could start doing local stories. We worked with UNESCO on World Radio Day and gained some back. Cost us no money. It resulted in more than 100,000 visits to our webpage, 57.5 million impressions on Twitter, and then about 400 radio events around the world. And this is the way to work. It is not, again, even with media, it is not to tell, but it is to engage them. And then, you know, you'll see some of this. I have very clever people in my team who do this infographics. It makes me feel good, but I don't know how much you can read in this, so bear with me. In the Americas, you can see this is what they've done in the last year, and it has been 1 year since, I think, the first case was confirmed on the 9th of May, so it's been more than a year. And you can see risk communication was a big part, and this is for you to look at later. This shows all the countries, the different risk communication things they've done. Again, not enough on community engagement, but other things. And if you look at all the experts mobilized, most experts were mobilized for risk communication. So you can see this is a big demand from countries for support. And if you look, just in a couple of weeks in April, how much, a big increase in the activities, and you can see a big increase, 53% in community engagement and risk communication. So just to show the demand in global public health response, regional public health response for risk communication and community engagement. The next slide is just my thinking, speaking with people, and we were at a big review meeting in Washington, D.C., where Brazil, Colombia, Dominican Republic, all the agencies involved were there, and we talked about ways forward. We think that there could be 4 things going forward in the next 4 months. Vector control, obviously, but really identifying what is an individual responsibility, what is a household responsibility, what is the community responsibility, what is the government authority. Sexual reproductive health and health education integrated into existing programs, including HIV, AIDS, and so on. National Zika risk communication and community engagement plans. And risk communication, community engagement for healthcare providers, which and tools to support them, which Asya will touch on. So I know Antwerp is in Europe, so your risk assessment for Europe was just released today. It will put a moderate to a low risk for most of your countries. About 18 countries have a moderate risk, and but we believe that there's good capacity in Europe. So I just added a slide, and this is going over my four pillars. I'll jump there. The remaining issues, slide 45. Travel to Brazil and Olympics. This is going to be an issue. Mosquito control is still going to be challenging. I think it's very difficult. I think we have to do source control. This is the big thing. Wolbachia infected mosquitoes. So I don't know if you know, please look this up. It's about 4 or 5 years experiment to infect mosquitoes with Wolbachia bacteria. And this bacteria actually stops mosquitoes from transmitting these diseases to us. This bacteria exists already in fruit flies and butterflies. So it already exists. This is why fruit flies don't give us diseases. Okay? And this was innovated in Sydney, in Australia. And now there are some pilot programs in Colombia and in Brazil. But it takes a couple of years for this to grow. Of course, this is not without controversy. Lots of people don't like Mother Nature being touched. Same with irradiated mosquitoes. IAEA wants to irradiate mosquitoes. The issue here is there's new technologies to look at the vector, and this will give rise to many more risk communication, community engagement issues. So, for example, if we have Wolbachia mosquitoes, we have to tell people to stop killing mosquitoes, because they're good mosquitoes. Because studies show as soon as you get rid of mosquitoes from one area, in a few weeks they'll come back again. So the messaging is going to be very tough. It is spreading to Africa and elsewhere, and in Africa the capacity is very different from the Americas. And I think we, with colleagues in Africa, already starting, we've planned a workshop in Cape Verde, inviting a few countries to be proactive about this. And in Africa, we don't have to talk about mosquitoes day and night, because there's malaria, there's a big yellow fever outbreak. There is still no vaccine. A vaccine is 18 months plus away. And then, of course, the issue of sexual reproductive health service delivery and access across the continuum. Here are some references I've used. I put this picture of I think this is a great-grandmother. You see the burden of caring for these children comes to the next generation. And here are some links, and this is how to spell my name in case you need to find me again. So I'm sorry I took a little longer than I wanted, but maybe I stop here and we listen to some of the questions or views that the participants have.
Okay. Thank you very much. Can I just ask how to pronounce your name?
Pronounce it Gaia. It's pronounced Gamhavage.
Okay, I'll call you Gaia then.
That's great.
So thank you so much, Dr. Gaia. This has been a very, very informative webinar presentation. We're going to take maybe a 10 to 15 minutes question answering session because we have to talk about the next presentation. So those who have questions, kindly either raise your hand or type your questions as a message, and the host will read your messages. You can ask your questions in French as well if you want to, and then we'll be able to do the translation. Okay.
Okay, Nadège, we have a question of Akriti Shahar. I will unmute. Akriti, can you hear us? Okay, we'll just wait. And then there is a question by Alison Kelly. I will now give her the floor. Hello, Alison?
Yes, I'm here. Can you hear me?
Okay. Yes, we can hear you loud and clear.
Okay, thanks. Thank you, Gaia. I just wanted to, most of our listeners will be in Africa. You mentioned this Cape Verde workshop that you were organizing and that you might be inviting countries. Can you just give us a little bit more specifics about when that will be and if there are countries present in this webinar who are interested, how they might manifest that to you?
Should we take a few questions and then respond together? That might save time. So I've got the question. Thank you, Alison. Any more? Okay, so while we're waiting, let me address this. Thanks again, Alison, for the question. Yes, I think it's great to hear that there are participants either from Africa or interested in that. As you know, there's a big yellow fever outbreak in Africa in several countries. Angola and DRC and Uganda are the most hit. They're two separate outbreaks, but nevertheless, the impact on people and government is the same. So as you can see, everybody is extremely occupied with that. But at the time, there is a small group of people who are trying to organize a Zika preparedness workshop. It will be in Cape Verde. It will be in the next 6 to 8 weeks. What we can do is we can communicate with the facilitators and the organizers as we get more information. But also, we also have a coordination mechanism with partners and agencies where we will be talking about this. And when I have more information, I will share it with you. But one of our practices is to try and make information from these meetings available to everybody. So again, that's something we could do. We use a lot of technology now. We try to transform, scientific meeting findings into, online resources. So all of that is on its way. And Alison, I know you have a connection with WHO, so I can certainly get that information to you. Over.
Okay, thank you. We have a question from Glenn Lavrak, and he wants to know what you mean by empowering people with regards to Zika. So if you can give more details about what strategies are we talking about when we talk about empowering people in the Zika response?
Yeah, I'm happy to answer Glenn's question. Since he is a colleague, I'm happy also to take it offline. And I'm much more keen to hear what your students and others want to say. But just a couple of lines, Glenn. Thank you. Really, it's about. So, for example, if we talk about vector control, it is about having community conversations, getting them to they go on the community walk, the neighborhood walk. They identify high-risk areas, they organize themselves, and they do the vector control. Our job is to make sure that the authorities are doing their jobs in things that communities can't do, so for example, fogging, and so on and so forth. So that's a very simple example. Sexual reproductive health requires a lot more community conversation than that, and what we do is we go through trusted community leaders, representatives who are able to have those talks. And I'm sure because it's linked to accessing health services and so on, ASEA might be able to continue as well. But I'm also tempted to ask you, Glenn, to answer the question because you are an expert. So let's see if any of the others have questions, and if not, maybe you could add to that. Thank you. Over.
Okay, thank you. We have a question from Jennifer. So maybe we can unmute Jennifer's microphone and we can hear from her.
Collaborative education session. I don't have a question per se, but I have something to add to your remaining issues slide. The remaining issues for risk communication. I think in Uganda we are having yellow fever reemerge because we are not having continuous education and engagement. An epidemic comes up and then it's dealt with, and then it goes to sleep, and then it comes again, and the communities are ignorant. They think it's a new disease, yet it's been around. So I think as part of the remaining issues for this slide, we should have their continuous education and engagement of the communities.
Thank you, Jen. That is an excellent comment. Absolutely. None of, we do emergency response as events, but life and education have to continue. I mean, one of the comments on yellow fever in Africa is, it's also related to policy, because yellow fever, we have a vaccine which is very effective, and currently the doses we're using gives lifelong immunity. I mean, this is such a strong tool, but because of competing priorities and other things, only vaccination was carried out routinely for yellow fever in certain areas. And then the global vaccine stockpile was about 6.5 million. Now, if you look at Angola, the capital city had 7 million people. So, in fact, the vaccine production wasn't fast enough and the vaccine campaigns weren't fast enough to limit yellow fever to Luanda in Angola. It spread now to 6 provinces in Angola and then across to DRC. Now, I know the one in Uganda is a separate outbreak, but I think it's a combination of continuous education, but also having policies to have the great tools we have available to everybody. I mean, you can vaccinate your country, people in your country could be very well educated, but if one case comes in and the vector exists, it can blow out of control. So I think there is a responsibility of international agencies as well as governments on top of continuous education for people. So thank you for adding that point. I will definitely add it in my slide, Jennifer. Over.
Okay. So we have 2 questions, one from Jessica from West Africa. She wants to know what lessons might have been learned from community engagement in the Ebola response. And another question from Mohamed Noor, and he says, since the risk communication started early on, how did this contribute to the overall investigation, the control response, and even in getting more resources?
Great question. Thank you, Jessica, for that question. So Asia, who's going to speak next, I'm sure we'll talk about lessons learned in community engagement. So I won't go too far there, except to say the lessons are profound. They are profound. And I think people who do community engagement, like Asia, understood this anyway. The difference is everybody else is beginning to appreciate it, even if they don't understand it. And that is why it was prioritized in these response plans. So I see as a manager, very big changes. I also see people willing to put money. In Zika, I see people willing to do social science and listening at the community level. So I think these are all legacies of Ebola, but Ashid can go into that. I think being first and being fast and being proactive is everything. Number one, it builds trust and confidence that you know what you're talking about and you're doing something about it. If you come in late, it doesn't matter how much money you have, people don't trust you. If you're there, the earlier you are there, the longer you have to understand. Understanding is the most important thing. And you can provide the tools that communities and others need to find the solutions they need. You can listen to misinformation and rumors, and if you have that trust, you can talk about what the correct information is. But if you don't have that trust, it doesn't matter what you know. There's a saying, people don't care about what you know until they know that you care. And to care, to show that you care, you have to be engaged early. Also internationally, because we convened early, it was very easy for WHO to take leadership. So in previous outbreaks and emergencies, we've had fragmented response. We've had much better coordination with partners. Governments are much happier with us because all the agencies are talking to them in the same voice. They're not spending 10 meetings a day, one meeting WHO, one meeting UNICEF, one meeting NGO. So I think all of these things are very important. We need capacity to be fast and to be present, and we're still building up that capacity. But what we see is governments are building their capacity for this area of work. This is the best news that I've seen. So I think it is translated into financial and budget space as well. So it's gone all the way from trust to monetary. Have we reached where we want to? Absolutely not. There's a lot more to do, but I've been in this field for a long time. I feel very happy that some steps have been taken and more people outside this area are beginning to appreciate it. So I think great gain. Maybe we take a last question now. Is that okay? You said you had one more and then we stop.
Okay, yes. We're aiming to stop at 20 past, so for 2:20. But we have two questions. We're going to hear from Basil, and then we're going to hear from Kurkulton, and then I think we will stop there.
Great. Go ahead. From Brazil.
Yes, hello.
Hello, yes, we can hear you.
Okay, thank you for your presentation. Beyond Zika, we have seen from your presentation that Zika has the same determinant and risk factor with other many diseases, chikungunya, yellow fever, and others. However, health system strengthening is the weakest part of the response to Zika. I don't know why is it so, because we have seen even with Ebola and yellow fever in Angola that it is the weakness of the health system and how we engage people, that is the weakness of the response. How WHO is dealing with health system strengthening now. Thank you.
So I continue, yeah, it'll be the next session. There's another webinar. Sorry, the previous webinar, sorry. So apparently there was a previous webinar on this. I'm sorry I didn't attend. So a lot of points were made there. Let me just share some thoughts. I'm not a health systems expert, but let me share a few thoughts. I think generally health system strengthening is very difficult because it takes a long time and it takes a lot of money. And this is a very important factor. You know, in Brazil, you are much stronger than in many, many countries that we often have to work with. So I think it's a very complex issue. I think the World Bank is now coming in and working with us and governments to look at resilient health systems, and not just for normal service delivery, but in times of emergency. I know there's a lot of negotiation going on that way, you know, health system strengthening is also about human resources, and there's a great deal going on. The difference between Ebola and others and Zika and health systems, from a sort of a stepping outside, just looking at it, I think in Ebola, we knew if we treated, managed people who were sick in a particular way, they had an increased chance of survival. At the beginning, you know, it was 90% fatality, but towards the end, it was about 50, and for a combination of factors, not just one. In Zika, we're not primarily looking to treat Zika patients, except in Guillain-Barré, where you need intensive care service. But what we're doing is engaging, monitoring, tracking pregnant girls and women, tracking their pregnancy, which is a 9-month, you know, process, and then following up the microcephaly babies for life. So I think there is a different sense of what needs to be done and urgency and so on. And that's why I think health systems is difficult in Zika, because you don't have the urgencies of dead bodies and demands created by that we saw in Ebola. I really have no answer for you, but these are some of the reflections I have. But it doesn't mean we shouldn't strengthen health systems to deal with all of this. And you were right about chikungunya and yellow fever and dengue. These require a lot of clinical management. Vaccines, you know, for dengue there's a vaccine, but it's only 30% successful. But 30% for a fatal disease is also not bad. So I really am not the expert to talk about this, but as a general public health practitioner and a former medical doctor, these are my thoughts. But I really think the definitive answer is in the health systems webinar. Maybe you'd like to look at that. And I apologize if I didn't give a very satisfactory answer, colleague from Brazil.
All right. Thank you so much. We're going to get the last question from Kay Kurkulton, and then we will start with the next presentation. So we'll hear from Kurkulton. And can I also ask that if your question has been answered, just raise your hand, because you raised your hand, so you can just click on the button so your hand is not raised.
Somebody unmuted. Mohammed has raised a hand.
Ms. Kurkulton is unmuted, but we seem to get no reply, so we might continue.
Okay. Well, in that case, then we can move on to the next presentation. Thank you very much.
Thank you all.
Dr. Gaia.
Thank you for the questions. Have a great day.
Hello everyone, can you hear me?
Yes, we can, loud and clear, thank you.
Okay, thank you very much. So, good morning and good afternoon from me as well. I think the presentation that Gaia just gave really sets the context well for what I'm going to be touching upon now, and that is what were some of the lessons learned around community engagement that we're putting into the Zika virus now, but also from past emergencies. And I'll touch upon some of the issues related to the linkages between health systems and communities, and how we need to be addressing some of the structural challenges that are there. So I think firstly we have to recognize that community engagement is not new. It's been around for a very long time, and in fact it was the declaration of Alma-Ata at the meeting on primary health care, where it really stated that the primary health care requires maximum community participation in the planning, organization, operation and control of primary health care. So community was right there at the very beginning, and what informed that statement was the experiences from countries like China, Cuba, Sri Lanka, Tanzania, and Venezuela, who demonstrated that when communities were put center stage in health programs, it actually did make a significant difference. And so what we have to do is look at what's happened since that time. And the world has changed significantly since that time. We've had 6 decades of experience in working with communities, and how communities have been involved or participated in many, many different health programs, from polio to HIV to malaria to TB. And now community engagement is coming up again as important. It seems that we haven't learned from those lessons, and so we need to really look at what's happened. Why is it that we are struggling to really approach engaging with communities in a systematic and structured way? And so there's a recognition that the world is different to when Alma-Ata the meeting was taking place. I know that in my lifetime, when I've reached the ripe old age of 50 this year, I remember speaking into a cassette to my family who were living in Somalia, and I had grown up in England. And this cassette was recorded, and then it was hand-carried by family and relatives so that they could then put it in their machines and listen to it. I'm talking about this to my 7-year-old daughter now. She just completely doesn't understand because information technology has changed the way that we communicate with each other. Information gets spread rapidly within seconds from one side of the world to the other world. We also know that because we are so interconnected, it has huge economic consequences as well. The SARS epidemic cost $30 billion US. We know that avian influenza in Southeast Asia significantly affected the tourism industry. And so, you know, as Gaia touched upon in her presentation, we need to be able to communicate risk in an appropriate way that helps people understand what the risks are and also act upon it. We know that today half the world's population has mobile subscription. We know that this is will continue, and now have 3.6 billion mobile subscribers at the end of 2014. So it's communication is a big issue, and it's going to become even more important as we move forward. But having said that, and knowing where we are, what is the current situation in public health? And so I'm going to touch a little bit about the context in which communication is working and operating within the public health system. And so when we look at health systems around the world, we can characterize them as being bureaucratic. There is some bureaucracy in some health systems than others, depending on which country you're in. They can be hierarchical. They are siloed with vertical programs. They're very specialized, and we have different groups of professionals and public health practitioners who specialize in different aspects of public health. And so we have entomologists who sort of measure the number of mosquitoes and how they breed and where they are. We've got clinicians, we've got epidemiologists who record the number of cases, and they look at the relationship between the disease and the transmission of disease. So we've got lots of different specializations that need to work together. We generally know that we have a very biomedical response, and that is our foundation. It comes from medicine. We also artificially separate the supply side, which is the service delivery, from the service uptake. And we have a division of labour between different stakeholders, and we'll say, well, you know, we will, as WHO, focus on surveillance and supporting service delivery, and other stakeholders can do the community mobilisation. And we really need to work very closely together, and we're seeing that happen now in the Zika response, and Guy spoke about that. And what we often find is that within the health sector, the groups that are responsible for community engagement, who are engagement specialists, have the least opportunities for professional development. They're often the most disempowered cadres of staff. And these are usually found within ministries of health, of the health education and health promotion units. And they are, as we found in the Ebola response, having to coordinate the biggest number of stakeholders compared to the other technical areas such as surveillance and infection prevention and control. The social mobilization pillar was by far the most complex pillar to be able to coordinate, but also to integrate into the work of the other pillars as well. So what impact did this have? What it actually does is that it limits opportunities to support community, because if the only group of people that are focusing on community responses are health promotion and health education people, and surveillance officers are not also placing communities first, if clinicians are not also putting communities first, then we get a disconnect. We get all of the responsibility for engaging with communities being placed on social mobilization or on health promotion. And we fail to see the opportunities for engaging that happen when we look at other kinds of health staff who also are working within communities and are also talking with communities. And it could be in the clinical setting, in healthcare. It could be in community settings where we have surveillance officers going out and doing case investigations and contact tracing. And this was particularly important for Ebola response. The Ebola experience demonstrated that community leaders and women were often ignored and bypassed. We had local and traditional decision-making mechanisms undermined. We recruited professional people to go and do mobilization and give messages. And again, Gaia referred to that it's not about messaging, and we learned that we had to listen and we had to try and find out where people were and what they understood for us to be able to engage with them. And this was one of the biggest lessons learned from Ebola. And the move away from a reliance on mass messaging and information dissemination. So this is the general strategy for controlling outbreaks, whether it be Zika or Ebola or any other kind of infectious disease. And Gaia talked about the human face of those who were affected by Zika. And I think we also have to think about the human face of those who are responding, because the relationship between those who were planning and delivering healthcare and doing response and their relationship to communities and those who are affected is key. And we need to look at those particular relationships, because this is where trust is made, and this is where trust is often broken when the interactions between key places may lead to misunderstandings or miscommunication if we just keep telling people what to do. This is where we often run into problems. And so this box, you can see it's got sort of behavioral and social interventions, and this is where we have anthropologists and health promoters and social scientists in there to help us understand the community. And what we learned was that those social scientists and those anthropologists need to also help us understand how the response is working. You know, how are we adapting and changing the ways that we provide services? How are we understanding the experiences that people have as they receive these services? And how do we use that to be able to make those services much more relevant, much more appropriate? And there's still a lot to learn from that. And so within Ebola, for example, we learned that the relationship between surveillance and health promotion and those doing community engagement was critical. For the first time, we sat with the surveillance group and looked at their standard operating procedures and said, where does engagement need to occur? You know, where do our surveillance officers need to be thinking about who they're going to be talking with? How are they going to address entry points into villages? How do they need to talk to them? What do they need to know? What are the key relationships that they need to build with the gatekeepers of communities so that they're able to do their technical work at the same time? And when we do that, it improves the quality of the work that they do, at the same time as building trustful relationships with people who were affected and who were in the quarantine households. And so for the first time, we developed a training program for them to be able to prepare for engagement. And there's a lot to take into account when we prepare. But also how to do it and how to continuously engage as they carried out their technical functions. So I think there are three critical and important shifts for public health when we look at community engagement and what we need to change. We often label people and situations and say, here is the role of the clinician, and here is the role of the risk communicator, and here is the role of the health promoter, and here is the role of the journalist. And I think we need to move outside of those labels and those boxes. And firstly, we need to look at the engagement paradigm. We need to change that. Gaia also spoke about this, the need to bring in social science, and we need to not sort of think that just by recruiting social scientists that's enough. We actually need to look at the role of social scientists the tools and methodologies that social science uses, and say, how can we take some of those tools and methodologies and give them to people doing non-social science functions, but how can we take them and help them use it so that they embed it and integrate it into the work that they do? So, for example, how can we help, again, surveillance officers understand, ask questions in a way that helps them understand the culture in which the families are living in, their relationship to the environment in which their families are living in. What does that mean for how disease is transmitted from the perspective of the families, the culture? And so, for example, things related to, you know, if my family member dies and is buried somewhere else, it has huge consequences for then what happens as a result of that, because then there are certain beliefs that say that people need to be buried in certain ways, using certain rituals. And if those rituals aren't performed, or if those beliefs are not valued, then there are repercussions. And so we need to understand how people live to be able to then say, what do we need to be saying to them, and how do we need to be organizing our response in a way that makes sense to those people that we're trying to help. And the third point is we need to stop this artificial separation between supply and demand and look at how improvements in service delivery, particularly around quality and accessibility and availability, how that impacts how people experience those services and how people take up those services. And we need to look at the role of the individual, the organization, and community practices and culture, as well as the culture and practices of those who are working within the health system themselves. So I'm going to quickly just talk about those three areas. So what do I mean about changing the engagement paradigm? And I think this is where we draw upon science, and often those of us working in this area get accused by our colleagues who've been trained in medicine that somehow it's a soft and fuzzy world that we work in, and it's enough to be kind and nice to people. And so what we've known from latest research is that, you know, how we talk and how we engage with people actually have physical consequences, and that there's a link between how we think, how we feel, and how we behave. And research is showing us that if we're in abusive relationships, then that inhibits the growth of fibers within the brain that integrates. And if we are in relationships that are nurturing and supportive, that supports the development of fibers that integrate within the brain. And understanding the human brain becomes important because when we understand how the brain operates and how the way that humans interact with each other affects the way that the brain functions, we begin to understand why changing behavior is so difficult. We begin to understand that the way the relationship between healthcare workers and how they relate and interact with healthcare users becomes critical. And so we can look at different ways in which healthcare workers can interact with people who are scared, who not only need information, but also need to feel that they're cared about and why it's important. We also know that functions that we thought were, you know, decision-making functions that happen within the brain happened in interpersonal space. So even though you may not be talking, just by being in close personal space with someone else, we know that decision-making is going on. And we're actually starting to have the instruments to understand how this kind of exchange of information at a non-visible level is occurring. And this is really critical because, again, it helps those public health professionals who are engaging with communities understand how they need to prepare for the kind of engagement that needs to happen to help people interpret and make sense and make meaning of what's going on, and then to be able to decide how they are going to deal with their particular circumstances. So those are a few key things that I wanted to touch upon here. So, okay, what are we drawing upon in terms of this different understanding of human engagement? And so there are bodies of knowledge and information. There are lots of very clever people around the world working on issues related to this. And you've got one sort of group which is looking at what is called interpersonal neurobiology, and this is the relationship between the human brain, the mind, and relationships. And it's really important, particularly when we talk about emergency situations, because when people are scared, the way that the brain works is that our decision-making processes become impaired. And so we go into freeze, flight, or flee syndrome, where the parts of the brain that is involved in decision-making, sort of high-level thinking, when emotion gets involved, we lose connection with that. And so when people are scared, we have to interact with them in different ways. So asking them to articulate what they're feeling, asking them to articulate what they're scared about becomes important, because as they talk and as they kind of make sense, they're engaging the different parts of the brain that helps them integrate. And so for healthcare professionals, it's very important to ask questions rather than give information and provide messaging. We also know that through the work of groups of people that are working on coordinated management of meaning, for example, you know, the unit of analysis moves from messaging and information to how do we help healthcare professionals manage difficult conversations. You know, how do we help them know how to talk to adolescents, how to talk to mothers, how to talk to men about really sensitive issues. And for Zika, we're talking about sex, we're talking about very sensitive areas where it's difficult for people to maybe be honest about what's happening. And so the relationship between professionals working in sexual and health reproductive services become very critical. And so we need to draw upon the tools and methods and ways of looking at human interaction from various groups of people. And the final thing is we need to start making seamless connections between horizontal approaches and vertical connections. And so this is a busy slide. But what I wanted to get across was that often when we talk about community engagement and social mobilization, we think of service uptake. We think of the purple part of the slide. We think of mobilizing communities. And there's a lot of engagement that happens before that. We know that program planners, people who make decisions about accessibility of services, the opening times, the training of staff within those healthcare settings, have a lot to do with, or they need to understand how community perceptions, experiences of service users, how that needs to be factored into the way that they design those programs and deliver those programs and services. So, and often there's a disconnect between the social science research or the research that's been done in a participatory way with communities, and how do we factor that back in to the way that services are managed and delivered. We also know that engagement needs to happen with communities. Okay, so something's going on. Yeah, that's okay. All right. And so there's a lot of work around working with those groups of people who plan and implement services with communities. And we also know that at the policy level, there needs to be engagement. Policymakers, those who are making decisions about allocating resources, need to understand the importance of community engagement, where it occurs, who does it, how it's done, so that we can integrate them in the way that it needs to be. And at the country level, who is it that is doing it? It is really the departments of health promotion and health education who are responsible for this. And so we need to help sort of expand what they do, not only to sort of focus on mobilizing communities, but work also on planning with them, work on also improving the service delivery and improving quality of services, and working with leadership. And that is a very different requirement from what health promotion is currently expected to do. Although having spoken with directors of health promotion units and people who work in there, they understand that their role is much bigger than the role that they're expected to take at the moment. And this is about sort of making sure that the behavioural and social dimensions of policy development, service planning, delivery is all factored in, and this has consequences for skills and competencies of various people in different functions, what kind of strategies are used, and the methodologies and tools. So what have I done here? Just need to go on to the next slide. Okay, so when we look at community then, community needs to be expanded. And often we think of community as being a geographical location, and this sort of came out from Alma Ata, and communities were seen as being in a certain location, but the world has changed, and community is different. Nowadays we choose which community we belong to. We have many different communities, sort of virtual communities that live on the web. We have local communities based on our interests. We are no longer living next to our families. We are sort of creating our own families from the friends that we have and the neighbours amongst which we live in, because the world is so different. And so when we look at community, we sort of think, well, you know, how are we to define community when we talk about health and quality improvement and universal health coverage and health system strengthening? And so what we did was sort of a group of us sat together and said, if we were to look at community in relation to the work that health systems need to be doing, what does that look like? And so we came to a definition of it being a group of people, maybe with diverse characteristics and mandates that may include policymakers, service providers, service users, health, other sectors, but who are united through a common identity, a collective vision. We wanted to be able to engage in some kind of joint action to address a specific health issue, and that could be Zika, it could be Ebola, it could be a range of other different health issues, and which recognises there are public health functions that are important depending on the nature of the problem that we're facing, and that there are groups of stakeholders who need to be working together, sitting around the table, talking with each other, again depending on what kind of public health issue that we're dealing with, and that community engagement becomes the intentional and purposeful interaction between members of whatever that community is. It's a very different way of looking at community, and I think it's a much more realistic way and it acknowledges that community will change. Who is part of that community will change depending on what the health situation is and who needs to be involved. So the final thing is, what are we doing in terms of community engagement and health system strengthening within our departments? And I think, as Gaia touched upon it again, there was a recognition that we needed to be working on it. WHO needed to be addressing this. And we hadn't done a very good job before of really looking at this in a systems way. And so within the service delivery and service department, we have colleagues who've been working on family and patient engagement for a decade. We've had community engagement work being carried out by different programs over the years. But in terms of, what is it that community engagement is and how do we need to be approaching it? We haven't sort of looked at it in a very systematic and structured way. And so one of the things that we've recognized is that we actually don't have a good theoretical model for understanding how community works. We have approaches that focus on individual responses, and so for example, cognitive psychologists will look at individual approaches and individual resilience. We have anthropologists who look at social side and the culture and how that affects people's responses. But we don't have a theoretical model that looks at the relationship between the individual, group and community, and how do we understand how people behave within the context of health. And so what we're trying to do is bring these disciplines together and coming up with a robust theoretical underpinning, and how do we then apply that in practice. We want to be able to look at building on the lessons learned and best practices that we've had from participatory models and the programs that have been running for decades. And we want to sort of see if engagement was a recipe. We know what the ingredients are. If it was a recipe, what would that recipe look like? And under what conditions would that recipe work? And so we want to be able to look at what would be a package of engagement interventions? So, and what impact would that have within not only responding to emergencies, but routinely? What impact would that have? And we also want to be building national capacities for engagement through the health promotion and health education units, as well as focusing on essential public health interventions. And seeing how we can start to build those capacities, so we start to address some of the systems problems, some of the structural problems. So with these three strategic areas, we want to be able to start doing that over the immediate term and over the coming years. Ideally, I think what we're saying is that health systems are composed of people. And we've had a lot of work on the building blocks of health systems. We know what those are. However, there is a human system which underpins the health system. It's about the people who have to take the guidelines that are produced, who have to implement them, and who have to build relationships and work together. And if we were able to have a human system which is balanced, aligned, harmonized, coordinated, if we can get people to work together, then automatically we can see changes in the health system itself and in the programs, and eventually have an impact on the communities that we're trying to reach. And I think finally, to sort of close, that community engagement is a shared responsibility, and that what Ebola and other public health emergencies has done, and I think what Zika has demonstrated, is that it's an opportunity for change. It's an opportunity for to really look deeply into the problems and say, okay, we know a lot. We know we need to do things differently. What does that mean? And how can we move forward to address some of the complex public health challenges that we're facing? So I'll leave it there, and I'll over to you for any questions that come up. Thank you.
Okay, thank you so much, Asiya, for this very good presentation. We're going to open the question-answer session now. So if you have a question, you can raise your hand or you can type your question as a message in the chat box. For those who asked questions during the previous presentation, kindly just drop your hand so we can see those that have questions now, because some hands are still raised from the previous presentation. So while waiting on the questions from the participants, I had a comment about the link between the brain and this interaction between humans. I think that was very interesting, and it stretches. Sorry, it really shows the importance of communication and behavior change, and the difficulty in actually changing behaviors.
Yeah, that's right. I think we often forget that when we develop habits, and human beings, we're creatures of habits. That when we do something, we are actually creating neural connections that the brain needs to be able to create shortcuts, so we don't have to keep thinking of how to do certain things. So, for example, I remember when I was starting to learn how to drive, and the first time you start to learn how to drive, you think you're never going to coordinate looking in the mirror with looking for people who are crossing the road, with looking behind you at the cars that are coming. It's an impossible task. And so what the brain does is it creates neural connections so that you begin to start doing it automatically. And I've had colleagues who said to me now, I drive home and I have no idea how I got there, which is scary, you know, because we don't think about complex behaviors, because that's how we've been built. And so when we look at, you know, telling people to stop smoking, telling people to stop burying dead bodies, asking people to eat healthily or to wash hands, we also have to make sure that we de-link the existing neural connections, and we create new connections, and we make people feel good about those connections, and we ask them to keep performing new behaviors, which will be uncomfortable, until these connections become substantiated. And so I think this is where those of us who are working in behavior change communication have to look at the interaction that over what length of time is it going to take people to be able to address some deeply held practices, and how do we get people to sort of say, I need to do this for myself, rather than I need to do it because someone else tells me to, because the motivation has to come from the people and not from outside. But this whole area of the brain and its importance in behavior and in human interaction is really critical. Yeah.
Okay, thanks very much. So do we have a question from Mohammed Noor? Because I can see that your hand is raised. Okay, so
yes, I have,
okay,
yes.
We're listening to you.
Thank you very much for the presentation. I just want to ask about the communities where you don't have like the structured community-based organizations, or if you have those, but the public health authorities just don't recognize them. How do you get these persons engaged? Thank you.
Okay. So thank you for that. What I understood from your question was where there are no community-based groups or structures, how do you engage the communities in those areas where it needs to come from the local authority side? That's how I understood it. I think it's an important point because what we've learned is that we have to use what exists, and if there are no community-based organizations there are community structures. There are ways in which families and communities organize themselves so that they can work together. So I haven't come across a community where there isn't some form of collective decision-making being there. And so one of the things that we have to do is look at how do communities make decisions? How do what kind of mechanisms exist? Who influences various families? I know from my own experiences that within the Somali community, women are very strong. You know, women as caretakers and organize themselves much better than men sometimes. And when it comes to sharing resources, there are women's collectives, and I know that my own mother was involved in what they call raising money. So each group would take turns in collecting money together. And so if you had 10 people who had put $100 into the pot, then they would give it to one person, all of them, which means that person had a substantial amount. And so this was one way of giving resources to someone when they needed it, and borrowing from others when they didn't need it. And so that's a very small example of the way that women may organize their resources that are within their control. And so we have to look for what exists. On the local authority side, I think what I've spoken about in my presentation is that engagement is a shared responsibility. And so those people who are providing services to communities need to engage with them and need to understand the communities so that they then are able to provide services in a way that meets those communities' need. And where there are institutions and organizations that have structured ways of working, then you work with those as well. Over to you.
Okay, thank you very much, Asiya. Are there any other questions? You can also type your questions in the message box. Okay, I think that that is all for the questions. There are no questions for now. So I would like to thank each and every one of you for being present here today and for having participated in our series of webinars on the Zika virus epidemic. I would like to thank you, Asiya, as well as the whole WHO team that helped us organize these webinars. You were the guest speakers, and we are very grateful for that. I would also like to thank ITM and the team that helped with getting the WebEx links and organizing these webinars. We will put all the presentations on the Harmonization for Health in Africa Health Financing blog, which you can see on the chat box. I think Annelise can help us maybe share the link with everyone. So we're going to put all the presentations on that blog, and you can have access to it on the link. So thank you so much again, everyone, for being here today, and we hope to be organizing more webinars very soon. Thank you very much, Annelise and Asiya.
Okay, thank you very much. Thank you.